trying to avoid discussing.
Right.
It's messy, it's socially taboo, and let's be honest, usually the punchline to a pretty terrible joke.
It absolutely is. But if you can, for a moment, strip away all that social awkwardness and the big factor, what you're actually looking at is one of the most high-stakes balancing acts the human body performs. It's a biological emergency system that is incredibly sophisticated.
Exactly. We are talking about diarrhea. And before you check out or, skip to the next deep dive, realize that this isn't just about an upset stomach. It's not about a bad burrito. We are unpacking a clinical chapter, chapter 23 to be exact, that breaks this all down into fluid dynamics, systemic disease markers, and the really complex pharmacology of how we try to control a system that has gone completely haywire.
That's really the mission today, isn't it? We want to move you from just being grossed out to being truly informed. Because when you understand the physics of what's happening, the actual pressure gradients and the tiny ion pumps involved, it completely changes how you think about it. It changes whether you immediately reach for the Imodium or whether you recognize that maybe your body's doing something really.
And we have a lot to get through today. We've got pathophysiology, the literal plumbing of the gut. We've got a drug cabinet that's just full of paradoxes, like medicines that are meant to cure your part can actually recognize. And we have some pretty heavy-duty treatments to talk about. Everything from simple dietary tweaks to, synthetic hormones.
We do. And we're going to be relying heavily on the clinical data here. We're looking at drug tables, at treatment algorithms, and the very specific definitions that separate what's just a nuisance from what is a potentially life-threatening event.
So let's start right there, where the text starts, with the definitions. Because I think in, common parlance, we use the word diarrhea pretty loosely. If things are a bit off one morning, people will say, oh, I have diarrhea. But clinically, that's not quite right, is it?
No, not at all. The clinical definition is actually quite rigid. It requires two things to be happening at the same time. You need an increased frequency and a decreased consistency of fecal discharge. And this is probably the most crucial part. It has to be compared to your individual baseline.
Right, because normal is such a relative term when it comes to GI health.
Precisely. Some people go 3 times a day like clockwork. Others go maybe 3 times a week. That's their normal. So if you're a 3 times a week person and you suddenly start going... But if you're already a 3 times a day person, that frequency alone isn't the marker. It's the change that matters.
Okay, that makes sense.
But I think the biggest takeaway from that definition section is that diarrhea is a symptom, not a disease in itself.
That's a vital distinction. It's the smoke, not the fire.
Exactly. It's a signal. It's a flashing red light on the dashboard telling you something else, be it systemic, infectious, or mechanical, is wrong. And the very first clue to figuring out what is wrong is the timeline. The text breaks this down into 3 chronological buckets. And knowing which bucket you're in basically determines your entire medical strategy.
Okay, let's walk through these buckets. So bucket number 1 is what most of us have probably experienced at some point. Acute diarrhea.
Right, acute. This is defined as lasting less than 14 days. This accounts for the vast, vast majority of cases. It's usually infectious. We're talking viruses, bacteria, protozoa, stomach flu, food poisoning, that sort of thing. The key characteristic here is that it is generally self-limiting.
And self-limiting is just doctor speak for it goes away on its own.
Essentially, yes, usually within 72 hours, maybe up to a week. The body identifies the pathogen, it flushes it out, the inflammation settles down, and life goes on. So the management here is mostly supportive. Just, don't get dehydrated. You generally don't need a whole battery of tests or invasive procedures. You just kind of have to ride the wave.
Okay. But then we hit that 14-day mark. If you've been dealing with this for 2 full weeks, you enter the second bucket, persistent diarrhea.
And this is the gray zone. It lasts for more than 14 days, but less than a month. This is a warning flag. It suggests that whatever the initial insult was, the virus or the bad sushi, it hasn't been cleared properly. Or maybe the treatment you tried failed. Or, and this is quite common, you might have developed a secondary issue because of the infection, like a temporary intolerance to certain foods.
And then we have the scary bucket, chronic diarrhea.
Chronic is anything lasting for longer than 30 days. And this is where the so what for the listener is huge. Because once you cross that 30-day line, the clinical approach changes completely. We stop looking for a simple stomach bug. We are not assuming you ate bad chicken salad a month ago. We start looking for things like functional disorders, inflammatory bowel disease, malabsorption issues, or even in some cases, tumors.
The text mentions looking for specific physical signs at this stage, right? Things that show the body is under some kind of long-term stress.
Yes, absolutely. We start looking for a history of previous bouts, for any significant weight loss, for anorexia, which in this clinical context just means a loss of appetite, not the eating disorder, and chronic weakness. At this point, you're not just treating a symptom anymore, you are hunting for a systemic disease. So if you're listening and you've had loose bowels for, say, 6 weeks, you are not in wait-and-see territory anymore. You need a full workup.
Okay, so timeline is our first filter. That's clear. Now I want to get into the mechanics. Section 2 of our source material covers pathophysiology. To me, this was the most fascinating part of the reading, this idea that the gut is basically a complex plumbing system that can fail in 4 very specific ways.
It's a great way to visualize it. I mean, the core function of your gut is to balance absorption and secretion of fluid. You pour massive amounts of fluid into your gut every single day: saliva, gastric juices, bile, plus everything you drink. The gut's job is to reclaim about 99% of that fluid before it leaves your body. Diarrhea is just a math error in that very important equation.
A failure of the reclamation project.
Correct. And the text outlines 4 specific mechanisms where this breakdown happens. If you can understand these 4, you can basically understand every type of diarrhea.
All right, let's tackle the first one. Active ion transport change. This sounds like something out of high school chemistry.
It is, but it's happening on a massive scale on your cell walls. Your gut lining has these microscopic pumps that move sodium and chloride around. Normally, they pump sodium out of the gut and into your blood, and water just follows the sodium. That's absorption.
Water follows salt. That's the golden rule here, isn't it?
Always. But in this mechanism, something goes wrong with those pumps. Either that sodium absorption decreases, so the salt stays in the gut and holds the water there with it, or the cell starts actively pumping chloride ions into the gut. And when chloride is pumped in, water just floods in from the body to try and dilute that saltiness.
So that's a pump failure.
Okay.
Mechanism number 2 is intestinal motility. This is about the speed of the conveyor belt, basically.
Right. The gut needs a Goldilocks speed. Not too fast, not too slow. If it moves too fast, we call that hypermotility. The fluid simply rushes past all the absorptive surfaces. It doesn't have enough time to be absorbed. It's like a water slide. Once you start sliding, you really don't stop until you hit the pool at the bottom.
But the text also says moving too slow can be a problem. That seems counterintuitive. If it's slow, shouldn't there be more time for absorption?
You would think so, and it's a great question. But if the flow stagnates, bacteria can overgrow in the small intestine where they're not supposed to be in large numbers. And that bacterial overgrowth then triggers inflammation and all these chemical changes that, yeah, you guessed it, cause diarrhea. So yeah, too fast or too slow, you lose either way.
Wow. Okay, mechanism number 3, luminal osmolarity.
This is what I call the sponge effect. If you eat something, your body can't absorb, let's say, a huge amount of an artificial sweetener or lactose if you're intolerant. That substance just sits in the gut. And because nature abhors a vacuum, or in this case, a concentration gradient fluid, is pulled from your blood into the intestine to try and dilute that unabsorbed stuff.
So the food that can't be broken down acts like a little sponge, just soaking up water from your body and holding it in the stool?
Exactly. And finally, mechanism number 4, increased tissue hydrostatic pressure. This one is more about simple physics. If the pressure in the blood vessels or the tissue surrounding the gut gets too high, fluid is literally forced through the walls and into the intestinal tract. You might see this in really systemic issues like heart failure or portal hypertension.
So we have pump failure, conveyor belt issues, the sponge effect, and pressure leaks.
Got it.
The text then takes these 4 mechanics and groups them into these clinical classifications. This is what helps connect the physics to actual diseases. The first one listed is secretory diarrhea.
Secretory diarrhea is the faucet left on. This corresponds directly to that ion transport change we just talked about. It's usually triggered by some kind of stimulating substance. The text mentions bacterial toxins. Cholera is the classic textbook example, or laxatives, or even certain hormones like vasoactive intestinal peptide, or VIP. These chemicals basically hit the secrete button on the cell walls and then tape it down. The body just actively dumps massive amounts of water.
And a key characteristic here is that it doesn't stop even if you stop eating, right? That's the tell.
That is the classic clinical test. If a patient fast stops eating entirely and the diarrhea continues in large volumes, it's almost certainly secretory. Your own body is driving the process, not the food in your gut.
Now you contrast that with osmotic diarrhea.
Right. Osmotic is the sponge effect. It is driven by what you eat. If you consume a bunch of magnesium antacids or, too much lactose for your system, you get diarrhea. If you stop eating those things, the diarrhea stops, usually pretty quickly. That's the main differentiator between secretory and osmotic. One stops when you fast, the other one doesn't.
Then there's exudative diarrhea. This one just sounds the most painful.
It implies tissue destruction. Exudative means things are oozing out. This is what happens in inflammatory bowel diseases like Crohn's disease or ulcerative colitis. The gut lining is inflamed, it's ulcerated, and it's discharging mucus, proteins, and sometimes even blood right into the tract. It's messy, it's destructive, and it is usually accompanied by significant pain and fever.
And finally, altered intestinal transit.
The speedway. This is where the motility is just all wrong. We see this in conditions like hyperthyroidism, where the whole body's metabolism is just revved up into overdrive, or in diabetes mellitus, where nerve damage over time can really mess up the signaling that controls the speed of the gut.
It's truly fascinating how interconnected this all is. You can have diabetes, which is an endocrine issue, and it manifests as a diarrhea because the nerves in the gut are misfiring.
It brings us right back to that first point we made. It's almost always a systemic symptom. The gut is so often the canary in the coal mine for other diseases going on in the body.
Let's move to section 3, the causes. We know about the bugs. The text is clear that most acute cases are infectious, viral, bacterial, protozoal. But I want to spend some time on drug-induced diarrhea. This feels like such a cruel joke. You take medicine to get better, and it just gives you the runs.
It is a massive, massive clinical problem. The list of culprits in the text is extensive. And you're right, antibiotics are probably the most famous one.
Right, I saw clindamycin, tetracycline, sulfonamides listed. We take them to kill an infection somewhere else.
And the mechanism there is essentially collateral damage. The antibiotic is trying to kill a pathogen in your throat or your skin, but it acts like a carpet bomb. It just nukes the peaceful, helpful bacterial community in your gut, your microbiome. And these good bacteria, they help us ferment carbohydrates and regulate fluid. When they're gone, the whole system goes chaotic.
But it's not just antibiotics. The table lists auranofin. I actually had to look this one up. It's a gold salt for arthritis.
Yes, exactly. Used for treating rheumatoid arthritis, we literally administer gold compounds.
And it causes diarrhea.
It's a very, very common side effect. It likely irritates the mucosal lining directly, or maybe it messes with those enzyme pumps we were talking about earlier. It's just a reminder that even precious metals can play havoc with our biology.
And then there are drugs for gout, like colchicine, and a whole bunch of heart medications.
Oh, cardiac agents are big offenders. The text lists quinidine, digitalis, digoxin, and don't forget the antihypertensives like reserpine and methyldopa.
So the takeaway here is, if you start a new blood pressure med and suddenly you can't leave the bathroom, don't just automatically assume it's what you ate.
Correct. Always check the label. But the most common and most commonly overlooked cause is probably magnesium. It's in multivitamins, it's in so many antacids like Melox or Melanta, and magnesium is just inherently poorly absorbed by the human gut.
So it acts as a sponge. An osmotic agent.
A very effective one. If you are popping antacids for heartburn all day and you're getting diarrhea, check if they contain magnesium. Switch to a calcium-based one, like Tums, and the problem often just vanishes. It's that simple osmotic principle in action.
Before we get to the decidedly unpleasant details of the symptoms, I want to touch on a more philosophical point the text raises. It compares diarrhea to a cough.
This is maybe the most critical takeaway for your treatment mindset. Think about why we cough. We cough to clear the airways of mucus or dust or foreign bodies. It's a defense mechanism. The text argues that diarrhea is often the exact same thing, but for the gut.
So the body detects a toxin or a pathogen, and it just pulls the emergency flush handle.
Precisely. The logic is flush it out. Get it out of the system before it has a chance to absorb into the bloodstream. The body is perfectly willing to lose some fluids to get rid of a poison.
Which implies that if we stop the flow, we might actually be doing more harm than good.
That's the danger. That is the central therapeutic dilemma. If you have a bacterial infection that's producing toxins, and you take a drug that paralyzes the gut to stop the diarrhea, you are now trapping those toxins inside, right up against the gut wall. You can turn a mild, self-limiting infection into a serious systemic illness.
So the old saying, better out than in, is actually sound medical advice here.
Within reason, yes. Obviously, you don't want to become dangerously dehydrated, but the goal isn't always zero stool. It's often survival and clearing the bug.
All right, let's talk clinical presentation. Or, as I called it in my notes, how to locate the problem based on where it hurts. The source makes a really interesting distinction between small intestine issues and large intestine issues based on how the pain feels.
It does, and that distinction is incredibly helpful for diagnosis. If the problem is in the small intestine, the pain is usually periumbilical, so right around the belly button or sometimes in the lower right quadrant.
Why the belly button specifically?
It's what we call referred pain. The nerves from that part of the small intestine all map back to that central area. The pain itself is usually cramping and intermittent, and you get borborygmi.
I love this word, borborygmi.
It's the best medical term. It's just the onomatopoeic word for those growling, rumbling bowel sounds. It sounds like a thunderstorm in your stomach. In small intestine diarrhea, the gut is noisy. It's working overtime, trying to push things through.
Now contrast that with the large intestine. How's that different?
Large intestine issues like colitis present very differently. The pain is lower down, in what we call the hypogastric region, which is that central low belly area. It's often described as a gripping or aching kind of pain, and the real hallmark is tenesmus.
Can you define tenesmus for us?
It's a truly miserable sensation. It's the intense, often painful urge to defecate, accompanied by straining, but you produce little to no stool. It basically means the rectum itself is inflamed and hypersensitive. It's screaming, "I need to go," even when it's completely empty.
So to summarize, cramps and a noisy gut probably equals small intestine. Gripping pain and that ineffective straining feeling, that points more to the large intestine. That's a pretty good heuristic.
It really helps narrow down the potential cause. But we also need to be on the lookout for red flags. The text calls out the toxic patient.
This sounds like a bad dating term, but I'm guessing clinically it's much, much worse.
Much worse. A toxic patient is someone who has gone way beyond simple fluid loss. They have a fever, they have hypotension, that's dangerously low blood pressure, and they have hematochezia, which is a medical term for visible, gross blood in the stool.
As you see blood, you have a fever?
You go to the hospital. Immediately. Do not pass. Go. Do not collect $200. These patients need IV fluids, and they need empiric antibiotics right away. The text is very clear on this. This is not something you manage at home with some ginger ale. This is a medical emergency because it implies the infection has breached the gut wall and has entered the system.
And speaking of management, let's move to Section 5, treatment strategy, specifically diet and fluids. The text lays down the law here, saying that diet is priority number one.
It absolutely is. And the first rule for most adults is the 24-hour rule. The recommendation is to stop solid foods entirely for 24 hours.
Just give the whole system a break.
Exactly. Putting more food into an inflamed, irritated gut just triggers more motility and more secretion. You have to rest the gut. Just focus entirely on hydration.
And definitely no dairy.
Absolutely no dairy, even if you love milk. As we mentioned before, a bad bout of diarrhea can temporarily strip the lactase enzyme from your gut lining. You effectively become temporarily lactose intolerant. So if you drink milk during an episode, you're just adding osmotic fuel to the fire.
So, what do we eat when we start back up?
Well, once that 24-hour fast is done, or if your nausea is pretty mild to begin with, you start with a very low residue diet. Bland foods, think bananas, rice, applesauce, toast, the brat diet. If vomiting is present, you stick to strictly fluids until it stops.
But there is a massive exception here for children. The text practically screams this point.
Yes, this is so important. The old adage, starve of fever, is actually dangerous here. For children with acute bacterial diarrhea, you continue feeding. Kids have incredibly high metabolic rates and very low reserves of energy. If you starve a child who has diarrhea, they can hit malnutrition and severe dehydration incredibly fast. You have to keep feeding them to maintain their strength and their ability to fight the infection.
That is such a crucial correction to the grandma's wisdom that many of us grew up with. Okay, now, hydration. We all know we're supposed to drink fluids, but the text gets really nerdy about what fluids. We're talking about oral rehydration solutions, or ORS.
This is honestly one of the greatest medical advancements of the entire 20th century. Simple ORS. It has saved millions of lives globally. The text compares the World Health Organization formula to commercial products like Pedialyte or Cerelac.
There's a really interesting note about rice syrup solids being used in some of these, like Cerelac. Why rice syrup? Why not just regular sugar?
This is just brilliant biochemistry. To absorb water, your gut needs sodium. But to absorb sodium, your gut needs glucose. They're co-transported. But if you put too much simple sugar, like sucrose, into the drink, you trigger that osmotic sponge effect we talked about. Rice syrup solids are long chains of glucose molecules. When they get into the gut, they slowly break down and provide the glucose needed to run the pumps, but because they are long chains, they don't spike the osmolarity, the saltiness of the gut fluid, nearly as much as simple sugar does.
Wow. So you get the fuel for absorption without the sponge effect of drawing more water back in.
Exactly. It's a way to optimize water absorption while minimizing any further water secretion. It's basically an engineered hack of the gut's own transport system.
That's wild. So if you're choosing a rehydration drink at the pharmacy, the specific carbohydrate source actually really matters.
It does, and plain water is often not enough because it lacks the electrolytes. Soda is terrible because it has way too much sugar and causes osmotic diarrhea. You need that perfect Goldilocks ratio of salt, sugar, and water that these solutions provide.
All right, let's open the drug cabinet. Section 6. The text starts with a pretty big disclaimer. Drugs are usually palliative, not curative.
Right, meaning they make you feel better, but they don't actually fix the underlying problem. And as we discussed, they might even interfere with the body's own flesh-it-out defense.
Let's start with the anti-motility agents. These are the heavy hitters. Loperamide, which most people know as Imodium and diphenoxylate.
These are basically opioids, or opioid derivatives.
Wait, Imodium is an opioid.
Chemically, yes. It works on the exact same receptors in the gut as morphine does. It just doesn't cross the blood-brain barrier efficiently, so you don't get high, but your gut definitely gets the message. We all know that opioids have a very famous side effect of causing constipation. In this context, we are exploiting that side effect as the main treatment.
So how does it actually work in the gut?
It essentially paralyzes the smooth muscle of the gut. It slows everything down. It delays transit time. This gives the intestines way more time to absorb fluid that would otherwise rush through. It effectively just stops the conveyor belt.
The dosing instructions in the text are very specific. 4 milligrams to start, then 2 milligrams after each loose stool. But there's a cap on that.
A hard cap, a maximum of 16 milligrams per day. And the big warning is, if you're still taking it after 48 hours and you still have diarrhea, you have to stop and see a doctor. You shouldn't be just corking the system indefinitely.
And because they are opioids, there are other risks.
With diphenoxylate, which is in Lomotil, it can actually cause central nervous system effects at high doses, euphoria, even addiction. That's why they almost always mix it with a small amount of atropine, which makes you feel pretty sick if you take too much, specifically to prevent abuse.
And again, we come back to that risk of trapping the bug.
Yes. If you have a high fever or you see blood in the stool, those signs of an invasive infection, you generally must avoid these drugs. You do not want to trap invasive bacteria like C. diff or certain E. coli inside an inflamed colon. It can lead to a condition called toxic megacolon, where the gut expands like a balloon and can actually rupture.
Yikes. Okay, let's look at the adsorbents, the sponges, things like kalinpectin or adipolgite.
These are much safer, but also generally less effective. They literally just sit in the gut and bind to things. They absorb toxins, bacteria, and excess fluid. They just bulk up the stool.
But they have a sticky downside, so to speak.
They bind to everything. They're completely non-discriminatory sponges. So if you take your essential heart medication or your antibiotic, and then you take a mouthful of kalinpectin, the clay will just bind to your medication and pass it right out of your body, unabsorbed.
So you're curing the diarrhea, but potentially leaving your heart condition completely untreated.
Exactly. Spacing out your doses is absolutely critical here. If you use these products, you need to take your other medications hours apart.
Next up are the anti-secretory agents, specifically bismuth subsalicylate. Most people know it as Pepto-Bismol.
A classic. It's actually a triple threat, which is why it's so popular. It's anti-secretory, it stops the faucet from being turned on, it's anti-inflammatory, it calms the irritation because of the salicylate component, and it's even antibacterial. The bismuth part actually kills some of the bugs. It really is the MVP for traveler's diarrhea.
Is there a catch with this one?
Toxicity if you overdo it. It contains salicylates, which is in the same chemical family as aspirin. You can absolutely overdose on Pepto. It can cause ringing in the ears, which is called tinnitus, and other toxic effects if you're just chugging bottles of it. Also, very important, don't give it to children with viral infections because of their risk of Ray's syndrome, just like with aspirin.
Good to know. Now, this next one made me laugh a little because it feels like a battle between modern marketing and old school science. Bacterial replacement.
Yeah.
Probiotics. Lactobacillus.
The text is a little bit sassy here, I noticed that too. It acknowledges that, yes, restoring the microbiome after it's been disrupted is a very good idea. We know that replacing the good flora helps, but it points out that you don't necessarily need a fancy, expensive pill to do it. The source specifically notes that a diet containing 200 to 400 grams of dairy products rich in lactose or dextrin, like, say, yogurt with live cultures, is equally effective at promoting recolonization.
So the milk counterpoint is basically just eat some yogurt.
Pretty much, assuming you can tolerate the dairy, and you have to remember that temporary intolerance warning, yes. The bacteria that are naturally in the food can work just as well as the bacteria that have been put into a capsule. Nature often provides the solution right there in the fridge.
And finally, we have to talk about what seems like the nuclear option, octreotide.
This is not for your weekend food poisoning. Octreotide is a synthetic analog of a natural hormone called somatostatin. Somatostatin is basically the body's universal shut-it-down hormone. It inhibits the secretion of almost everything: gastric acid, bile, pancreatic juice, you name it.
So when on earth do we use this?
In cases of severe, life-threatening secretory diarrhea that's associated with certain types of tumors, specifically carcinoid tumors or VIP-secreting tumors. These are rare cancers that produce hormones that basically force the gut to secrete water nonstop to the point where the patient can literally die of dehydration within days.
So this drug is powerful enough to override a tumor's signal.
It is. It's an injection given subcutaneously. And it comes with some heavy side effects. Gallstones are common, nausea, abdominal pain. But in those very specific cancer cases, it is an absolute lifesaver.
It really puts a simple case of the stomach flu in perspective.
It really does. It shows you the sheer raw power of the gut's secretory system when the brakes are cut. It highlights how incredibly complex and tightly regulated these systems in the gut actually are.
So bringing this all together, we've gone from the timeline to the plumbing, the causes, and the entire drug cabinet. What's the big final takeaway for the listener?
I think it's a newfound respect for the symptom itself. Diarrhea isn't just a nuisance. It's a decision your body is making. It's a physiological calculation. I need to flush this toxin out, and this is the fastest way to do it.
And our job is to interpret that signal correctly.
Right. Is this acute, where I probably just need to hydrate and wait it out? Or is this chronic, where I need a serious investigation? Is this a defense mechanism that I should support with hydration? Or is it a mechanical failure that I need to stop with drugs?
And just be mindful of all the trade-offs we talked about. Taking the Imodium might save your road trip, but it might also prolong the infection. Eating the yogurt might fix your gut flora, or it might just trigger an osmotic flood if you're temporarily lactose intolerant.
It's all about context. And honestly, just stay away from the sugar-free gummy bears if you have a long drive ahead of you.
Yeah.
That's the osmotic diarrhea lesson that everyone seems to learn the hard way at least once.
Solid advice. Pun intended.
I walked right into that one.
Well, that's a wrap on Chapter 23. Hopefully, you'll never look at a bottle of Pepto or even a simple glass of water the same way again.
Stay curious.
Stay hydrated. We'll see you in the next deep dive.